Good morning, everyone. I'm very happy to share the dais with pioneers in ophthalmology today. And all of us, what we love to see on first post-op day is crystal clear cornea and a happy patient in 20/20 vision. So this is what my talk is going to be about. I have divided my talk into three broad categories: the preoperative evaluation, the various intraoperative concerns, and the postoperative management of complications. So before we go on to the slit lamp, we should look at the eye as a whole, whether the patient has very deep-set eyes or prominent eyebrows with a narrow palpebral aperture. In these cases, we should adjust the chin of the patient so it gives us enough space to maneuver. Also, it's good to consider a temporal incision so that we have enough space. Then let's talk about looking at the cornea on slit lamp. So first thing is whether the cornea is clear or whether it has some haze, or if there are any footprint scars which are vascularized. Then it's a good idea to go back and ask the patient whether there is any history suggestive of prior HSV keratitis, because the endothelium might have been affected prior to that. Then let's take a closer look at the endothelium by the technique of specular reflection. So to do this technique, we should keep the intensity of the light to a maximum with the angle between the illumination and the objective unit around 45 to 60 degrees. And the angle of incidence, if we keep this equal to the angle of reflection, then we get a good specular image. And the beam should not be very thin like an optical section. It should be a parallelopipe beam with a good moderate magnification. And then we should try to catch the reflex. Wherever we get the reflex from the slit lamp, we should try and catch it and focus our beam there. And right when we focus on the endothelium, we'll see this mosaic of beautiful equal-sized hexagonal cells, which is the normal corneal endothelium. Now, sometimes we have a patient coming to us on when we just do a direct examination, we'll be able to appreciate these pigments on the endothelium. And when we see this, then we should try and do a specular and look more closely. And lots of times we'll see these guttate changes which can be appreciated in this picture. And it actually looks like somebody has jumped on the endothelium, which is typically described as the beaten metal appearance. So when we have a picture like this, one investigation that comes in handy is specular microscopy. It helps us confirm our suspicions whether this patient has Fuchs endothelial dystrophy. So this is the picture of the same patient, the photograph that I showed previous to this. And these areas that you can see over here, so these are where the guttae were. And although the cell density is more than 2,000, but the hexagonality is less than 60, and the coefficient of variation is more than 30, just borderline more than 30. So this, we have to be very, very careful while doing the surgery. And we could not get a specular image in the other eye of this patient. And this is the other eye of the same patient. So this patient had undergone cataract surgery elsewhere 2 years back, and this eye has now decompensated and needs an endothelial keratoplasty. So sometimes these cases progress further and they actually develop corneal edema, and the patient can compare of blurring of vision, especially in the morning, as well as glare. And it's a good idea to do a pachymetry, and if this value comes out to be more than 640 microns, then we can combine DSEC with the phacosurgery in the first sitting itself. So any value more than 620 microns, it predisposes the cornea to decompensate postoperatively. Another important entity is pseudo exfoliation syndrome, because the pseudo exfoliative material tends to get deposited on the endothelium and cause problems later on. Also, these cases can have small pupil and zonules might not be that intact, so it can lead to a complicated surgery. So if we have a complicated cataract with a small pupil, or if it's a very hard cataract and we are anticipating a prolonged surgery, in all these cases the energy delivered or the maneuvers in the anterior chamber are more, and there are more chances of cornea decompensating. So in case of uveitis, it is essential that we control the inflammation at least 3 months prior to surgery, because if the eye is not quiet at the time of surgery, there can be heightened postoperative inflammation, and that itself can lead to transient corneal edema. So if we have a small pupil, then we have various methods to tackle this. The few of them important ones are sphincter sparing methods, or we have the sphincter involving methods, like you can use iris hooks or Malugin rings. If you don't have these available to us, we can do multiple very, very small sphincterotomies. But it's important to remember that in case of floppy iris syndrome, iris hooks help a lot, whereas sphincterotomies should be avoided in these cases because the iris is already quite lax. Then, of course, the viscoelastics come in very handy in our surgery. We have the dispersive agent, which have chondroitin sulfate, which have a good ability to coat and protect the cornea during the surgery, and the cohesive ones, which can maintain the space and make the surgery safer. So Arshinov initially in 1999 had described the soft shell technique, which basically illustrates how we can use both of these to our advantage. We can use the dispersive ones to coat and protect the cornea, and the cohesive ones to maintain the space. So first we inject a dispersive viscoelastic, and then underneath that a cohesive one. So the dispersive goes and sits right next to the cornea, and the cohesive one comes out while we are doing the phacosurgery, but dispersive protects the cornea throughout the surgery. And then there were various modifications of the same technique introduced later on, like we can inject BSS right under the cohesive one so that it gives us space and we can do a capsulorhexis easily. Another important thing to keep in mind is how is the anterior chamber depth preoperatively, whether the patient is a hypermetrope and whether is a patient of chronic angle closure, glaucoma, or if it's a traumatic cataract. In cases of traumatic cataract, there might be an intumescent lens and the anterior chamber might be very shallow, gives us lesser space to work in. So in these cases, I personally think it's a good idea to give a peribulbar block rather to have struggle throughout the surgery. And if the pressure is high, to wait for some time, give preoperatively mannitol, give a good massage or apply a super pinky, make the pressure come down, and use of cohesive viscoelastic substances and so that the chamber is well formed and we do not damage the cornea. Postoperatively, if we have a shallow AC, we must do a Seidels and rule out a wound leak. If it's a leaky wound, then we should not hesitate to take the patient up again, form the AC, and put a suture wherever required. Because the touching of the endothelium to the iris can then itself decompromise the cornea later on. The intraoperative corneal trauma can also be caused by improper handling of the instruments, so we should be very, very careful while entering and taking the instruments out of the anterior chamber. Sometimes we can cause inadvertent DM detachments while doing this. Also, we should keep looking at our left hand, whether the chopper is anywhere close to the endothelium. The amount of fluid going in as well as the concentration of the intracameral antibiotics and the liglocaine that we use can add to the toxicity. And wide variations in chamber can also cause transient corneal edema. So all of these things we need to keep in mind when we're doing the surgery. So if we use a lot of ultrasound energy and if it's a very hard nucleus, then we must make an adequate trench using a Kelman tip. And this capsulorhexis should be large enough so that we can maneuver easily and we are not struggling throughout the surgery. And if we have nuclear fragments which are very hard and we are not being able to catch hold of them, they are tumbling, then we should give a good vacuum, create a good vacuum seal, and then come in the center and then aspirate them. And we should always know when to convert. So if we have a picture like this, an intraoperative DM detachment, if it's recognized on table, then we can go ahead and put the air on table itself and this will attach. But if this is missed and we see this kind of a picture on first post-operative day, and if this DM detachment is unlikely to resolve by itself, if it's in the center affecting the visual axis and causing corneal edema, then we should go ahead and do a desmetopexy. So various agents used for desmetopexy are air or sulfur hexafluoride or C3F8. I personally think air is much better because it has the shortest absorption time with least risk of endothelial toxicity, and the long period of tamponade as such has questionable efficacy because we just need a good tamponade for good 8 to 10 minutes, and that is good enough to attach the DM in place. So this is a video. One of our residents had operated this case. And there was a DM detachment. So what I'm going to do is, first thing to remember is always enter the anterior chamber far away from the side of Descemet's membrane detachment. Otherwise, we can increase the DM detachment. Here I'm taking a 26 gauge needle. I'm not going from the previously created side port. So I take 100% air, go in with the 26 gauge needle and point my needle obliquely. So it's not straight. It's pointed a little obliquely so that when I retract, all the air doesn't come out. So maintain a good pressure, get a good tight air fill, keeping the pressure high, and make sure that there's no leak from anywhere. And then I like to put a swab stick while I'm retracting this. And then it's important to retract it obliquely with a jerk. Then we can iron out any folds if there are any folds present, and then wait for 8 to 10 minutes with a high pressure, then release some of the fluid, keep a mobile air bubble, and this should work in most of the cases. Last resort, of course, is endothelial keratoplasty. As a cornea surgeon, I would just like to highlight that if we have a case in which there's corneal edema and it has been 2 months or so after the surgery and it is not resolving and if the cornea is decompensated, we should not take very long to take the call of doing an endothelial keratoplasty. Otherwise, the stromal fibrosis might set in and this will not have a very favorable outcome later on. Thank you so much for your kind attention.